they don't talk to each other. And I'll share a story about the city of Atlanta. Now, the city of Atlanta has a lot of hospitals, and I work a lot with the Chamber of Commerce, also with the Metro Atlanta Chamber of Commerce, and Atlanta has one of the biggest health IT, very healthy health IT industry. And there are lots of hospitals in and around Atlanta, and they all used to. McKesson is a huge company that used to have a big EMR product, and McKesson was based in Atlanta. So a lot of the hospitals were McKesson and Cerner products. They used to use McKesson and Cerner products, and of course they didn't talk to each other. So now Epic has come up to the market, and Epic has a product that supposedly is a little bit more transparent and a little bit more amenable to interchange of information and interoperable. So now all of these hospitals are suddenly jumping and they're jumping through hoops to go through Epic, and they're all changing shops and coming into and going through Epic implementation. Now we'll have to wait and watch whether all of these hospitals, after implementing Epic, now of course because they're going to have all Epic, they'll be able to talk to each other, but that doesn't mean that one hospital that has Epic is going to be able to talk to the other hospital that has a McKesson product or has a Cerner product. So of course they don't talk to each other right now.
Okay, if they don't talk to each other, is there an initiative from the government side to have anything so that they can talk to each other?
Yes, there is. There is actually a lot of initiative going on information exchanges to make sure that these softwares actually do ensure that they have open access and they can communicate with each other, because that's really the bottom line. Because if I am going to say a primary care physician who has a certain software, and then I go to see a specialist who has another software, and if they're not talking to each other, then the whole purpose of EMR is kind of getting failed, because they're having to repeat the same test, and it's really not hitting either the quality of patient care or the efficiency that's built into the EMR.
Why I put this question here in forum is, I request everybody to look at the standards, and if from the day one we conform to the standards, maybe we don't face this challenge and difficulty later on. Because why I'm raising this question is, if there is some initiative, how they are going to do it. Because when I will be prepared for it, when I roll out national EHR EMR standards and I look forward for it, already there will be certain people already and certain institutions, Apollo already in the fray. Then how will I have them all together? That was the basic idea to talk about.
I am Dr. Mishra. We have been experienced with managing this HIS from 98 to 2008, when decision was taken to upgrade this hospital information system. This is a case study I am going to share with you, that when you start upgrading your existing system to another system, then you get another vendor, and of course nobody comes with to prepare to test whatever is there to repair it or refurbish it. And they come with their own solution, and they say they customize it. And this word customization has different connotations. And many things they accept, many things they don't. But at the time of tender, everybody says, yes, we'll do all customization. This is one of the stories I want to share with you. So any hospital is refurbishing their old software to new one. So you have to be very, very careful to build in your system study about all integratives that you want to integrate. The second point is migrating the old data to the new system. That's a huge task. And my hospital is trying the vendor is working with us for last 2 years. Until now, this migration job is not over. It is 10 years data, and nowadays you're talking about all those big data and all these things. The third point I want to raise, and many members in this hall are members of this national initiative. I think, Arvind, we are also a member in that. You realize that when you introduce this national EMR, can you imagine what you're going to have? I think we'll leave no hair in our heads by pulling all the hairs around. When in a hospital you have so much a problem in implementing, just imagine at national level, where your stakes in the public health and stakes in the academic medical institute and stakes in corporate hospitals are totally different. Now you may have a very good example of implementing a software system for Tamil Nadu public health system, that when you talk of integrating that into a tertiary level institution, it is not going to work. That's my apprehension I am sharing with the members here, because that's the future we are going to be prepared for.
My name is Rinku Kachera. I am a work practice researcher at Xerox, and I have a question for Dr. Arvind Shivaramakrishnan. It's about the training. that would you say that at any way that you can reduce training, say by, as Dr. Shweta Sneha mentioned, by reflecting or understanding work practices, you actually can probably make the software design such a way that it sort of inherently takes the work practices into account and by that reduces the training.
I would actually love to understand that particularly in healthcare organizations, the attrition is very large. People move, and given the shortage of staff, people are being skilled in multiple areas. So there is a constant need for it, and to Dr. Damija's question also in terms of that, it has to be done in many ways, interdepartmental, pushed from the organization, peer-to-peer, as well as electronic methods of learning such as recorded videos and all of them. But I would stress on the fact that training should never be minimized, because only then you're going to be in a situation where you can be efficient. And the reason I say that particularly is, remember, patient is the center of our universe. So wherever we go wrong, we cannot go wrong with the patient. So with that intent in mind, we should not reduce.
One part is addressed. The interesting thing is we had both a technology, a service provider, as well as a healthcare organization represented. So one to each, one to Mr. Krishnamurthy from TCS and the other to Mr. Rajgopalan from Sundaram. Now this is about, on the one hand, Mr. Rajgopalan mentioned about obsolescence being a critical concern while adopting EHRs. Now, to what extent, so from an organizational perspective, to what extent does that weigh on your mind when making a decision about whether to go ahead or not? I'll also take the converse of the question to Mr. Krishnamurthy. Since you had mentioned a very catchy term, eternal medical record. Now, how do you address this? I mean, from a service provider perspective, how do you address this concern which would always pop up about obsolescence there? And what decisions do you take on your products and platforms to avoid obsolescence? So essentially there are two sides of the coin. Because we can't hold the technology, make it fixed for all time, for eternity, right? So the technology is, the technological change is a given fact. So in this context, both sides of the coin.
The obsolescence question is inherent or accurate fashion what the world is going to look like 6 months from now, a year from now. Technologies hit you, all kinds of things hit you. This happens in a very short cycle time, but the process of developing your own EHR, if we are to take the advice that all of us have given over here, is something that in the best of situations will take you at least a year and a half to 2 years. It took us that long. And during that period of time, you will find that things will change. Technologies will change. For instance, initially we thought that using dot matrix printers was a great solution. But then as many other things happened, the way we needed to cosmetize our reports, the way we needed to fall in line with a lot of lab integration and all that, the technology was completely, wasn't going to work for us, and we had to switch to low-cost laser printers, which was a step up in terms of quality, but was a definite hit also in terms of cost. The same thing will hold good. You can never accurately estimate your hardware requirements. For sure, whatever the people tell you, by the time you're done implementing whatever you have to implement, your server won't be fast enough, your LANs won't be fast enough, all kinds of things will change. I mean, somebody just started off by saying this is something in constant evolution. And that need for constant evolution, even as you're putting it in place, drives up costs. You have to be prepared, and it's kind of a very hard situation because you can't start with a project saying, I don't know how much it's going to cost. But you have to be prepared for a large element of surprise. It may even do it the opposite. Something may come in that may suddenly reduce costs for you. And that constantly happens in there. So it is both ways. And by obsolescence, I don't mean obsolescence only in a negative sense, in the sense of increasing costs, but in the sense of having an impact on what you're trying to do. You're literally dancing on a very shifting dance floor. Does that answer your question?
Yes, sir. How do you address it?
Yes, so about 5 to 8 years back, if you are putting together an EMR requirement to be done in your organization, and if you are talking to a company like TCS, Probably you may not put a requirement that the reports needs to be available on a tablet or on a mobile phone. It should have an SMS interface, and the patient's laboratory report has to be emailed to patient. Probably you might have not thought through that kind of requirements because socially and technology environment was not conducive to it. But today, if you are working on planning to do an AMR, you also start progressively thinking what is the latest part of it. So it is not the change happening and the obsolescence happens only in technology. It is also the way, the functions which you perceive to do it. So which is generally what we have seen. It is more of a pull which is driven from the user and the customer and a market at large. And then you take the technology, what is happening on the technology industry at any point of time. We talk about obsolescence happening very fast. Of course, I agree with that concept. But today, if you look at it, an obsolescence, what it can cause take the hardware out for about this discussion. In an IT technology environment, what kind of an obsolescence can happen today? There are about 3 companies which is driving this obsolescence from a software usage perspective. 1 being Apple, 2 being Microsoft, and 3 being Google. And each one of them are trying to create a technology which is in terms of, well, Apple trying to put all the knowledge into the gadgets, and Google trying to put in all the knowledge and intelligence in the back, and the Microsoft is doing somewhere in the middle ground, and all other players of software vendors and mobile phone vendors and tablet vendors, everybody is playing around this. So we as TCS, this problem is not only meant for an hospital information system or EMR. This technology change, which is, it's a wide range. And our majority of our customer, they are always in the high end of the market of economic growth, where the technology change has happened first. And we happen to be a service provider and a consulting firm for them. We have to think on behalf of them what is going to happen in the next 5 years to 8 years to really plan. And for example, today we talk about big data and mobility application as a second word, but in TCS we started talking this about 5-6 years before, that what it will really impact our customer and how their thing is. Because we are the same people who have put the application for them. We are the custodian and have the ownership to ensure the customer is effectively using it. So we make a lot of investment in constantly evolving technology changes, how we cope up with that. And that is the kind of services we can adopt to us to really deal with this obsolescence. And that is the way we approach it, and we are constantly successful. And given our credibility in the market and the most of our customer significance on that, which is, we are fairly successful in taking through the customer from one change to the other change. And that's the way we approach it today. And that's the best answer I can give it to you.
And finally, the take-home message is, you want the benefits from EMR, one has this. I thank all the speakers for making this a successful section and keeping all the audience awake. Thank you all.
The certificates by Healthy Schools. Small request to all our speakers for tomorrow. Kindly submit all your pen drives and all the information at our video and audio section, please. For the tomorrow's presentation, I would request all our speakers to please submit their videos and PPTs at our audio-visual section, please. Thank you. World, we have our chairpersons, Lord Nigel Crisp and Mr. Stephen Yeo. Lord Nigel Crisp, former CEO, NHS, United Kingdom, is an independent crossbench member of the House of Lords, where he most well-known publication being Turning the World Upside Down. The Search for Global Health in the 21st Century was his best writing. Mr. Stephen Yeo, Vice President and Executive Director, HIMSS, Asia Pacific, Singapore. Mr. Stephen is the Vice President and the Executive Director, HIMSS, Asia Pacific and General Manager, Analytical Asia Pacific and Middle East. He has 22 years of international business experience working with governments, users, and providers in both high-tech and healthcare industry. Now I would request our chairperson and our speakers for the fifth session to please assemble on the stage, please. Thank you.
I just want to remind all our panelists is that due to a time constraint, we have 10 minutes each for presentation, and then there will be an alert at 9 minutes to tell you that you have 1 minute left. All right, and we are going to bring to you the topics on e-health around the world. The good thing is that on the panelists here, we do have people from the North America, right? We have Mark from the Latin America as well. Yeah. The Caribbean, right? Then we do have also from the Canada, which is Chris here. And then we have people from Belgium and UK and Singapore and also New Zealand. So now I'm going to leave it over to my co-chair.
Well, I think I've got nothing else to add to that because we're in a hurry. And I think we're going to introduce Frank. So do you want to hand it back to you?
All right, our first speaker will be Mr. Frank Levens. He's the board members, secretary, treasury of this ISF TEH, and he's a pioneer in the field of telemedicine. So let's welcome Frank.
Okay, thank you very much. Gentlemen, yes, we are going to take you on a trip around the world, which I think is also a very important dimension in all this. Do we have the slides? Or? Is a universal right. And in order to deal with that, there has been a wider variety of health systems around the world, with as many histories and organizational structures as there are nations, which certainly doesn't make it easy. And with the upcoming of e-health, telemedicine, whatever you want to call it, since 20-25 years, a new dimension is allowed to reach out globally. And e-health definitely requires a global approach. Now, what are the global issues on health? Well, there's a population increase, aging population, chronic diseases, which we find in most of the developing countries, and poverty and low health budgets, scarce human resources, lack of infrastructure, and need for improved access in the developing world. And so e-health came, and we define it, and we have defined it in the editorial of the recent issue of the Journal of the ISFTEH, as the use of modern information and communication technology for health, which is a reduced version of the official WHO definition. But in order to achieve that, you have to rely on IT achievements and connectivity infrastructure. If you have one and not the other, it's useless. And in the field of health and medicine, it's the first time that you need to play at different levels. Not only with one keyboard like you do on a piano, but more like on an organ with 4 or 5 keyboards at the same time. And you have to learn to be skillful in all that. E-health encompasses a lot of promises. You see the list here. But in order to fulfill these promises, it requires an approach at global level. Of course, you concentrate on your own territory in the first place, but you have to be aware of what's happening somewhere else. Because nowadays, thanks to e-health, you're able to provide healthcare everywhere and reach those that are in need, as well on land, at sea, or in the air. And with so many applications and solutions all over the world, you need to have a global vision on e-health developments and achievements. Because we cannot lose the time or the energy or the money to reinvent the wheel. There are too many things, of course, to know or to have to know, but by the same token, you have to be mentally prepared to do it. So let me introduce you the International Society for Telemedicine and E-Health, of which I'm the secretary. That society, which has been created 15 years ago, has the mission, it's basically an international federation of national associations who represent their countries in telemedicine and e-health. And it exists to facilitate the international dissemination of knowledge and experience in that field and to bring experts together. So meetings like these are very important elements in that network. In order to fulfill this mission, we organize a lot of activities and we promote and support activities around the globe. We assist the startup of national societies, national organizations. The networking is very important, but at the same time we touch also the scientific and academic aspects. We have annual international events and we support our member countries in the field on their strategies and policies, regulations and standards, etc. Right now we have members throughout the various categories of memberships from 79 countries around the world. And it's not enough to have a program, you have to communicate it. So, we do that through our website. We do that through a discussion forum, which is accessible for the members on the website. We also have created 2 years ago a quarterly newsletter, which reaches out not only to members, but to our complete database of more than 20,000 people around the world. We have created at the academic and scientific level a journal which brings long papers, peer-reviewed, which we hope will also contribute to a better knowledge of what's going on. And then we have just put last week on our website a repository of the national e-health strategies. You know that WHO and ITU have recommended countries to develop and write the document on their national e-health strategies. And we have already found several true, but now we want to make it accessible under one click. And of course we call upon all the countries that have these or will have those to also let us have these documents so that we can add them. And then we have our working groups, and I would just like to point out that just a few. Well, education, of course. We have a working group on open source, which is also working very hard and I think very efficiently. Students, they are the future. The medical students and informatics students. I was recently at a conference of the International Federation of Medical Students Associations. They need to be introduced at that level to e-health and telemedicine. And so it's a very important task. I'm also very happy to see that that working group is doing fantastic jobs. And then another one, women and e-health, which has been created last year. Men talk, women do. And I think for us it's also extremely important to recognize that. And then one other element, and I heard some comments about that this morning, starting working groups in their own language. We have started with Portuguese and Spanish, but I'm sure that countries like India can use that as well. And then we have our annual event, Meditel in Luxembourg, which has been mentioned before. But here I would like to point out that we have gathered on our website what we call a knowledge resource center, where you can find open access, all the presentations, abstracts and PowerPoints from the last 10 years or more, and that's more than 3,000, which is, you can find them chronologically per country and per topic. And we have also created an annex section of evidence-based presentations. So very interesting material to go through. Then we have our international meetings, so the very next one will be in Japan in October with the Japanese Telemedicine Association. I'd like to make the remark that sometimes it's just as important to know where to go for available information as to receive the exact information itself. And as far as we are concerned, through our website, through the Medical website, these are certainly efficient tools, but there are so many others. So do the work to go and search. You know, in the past, there were no doctors, there were no hospitals. There was one big cemetery. Today, thanks to e-health and also the future, the accessibility of doctors and hospitals to millions of people has improved tremendously. There will always be cemeteries, we know that, but at least there is a major difference and it has to be used appropriately. So I'll end with two pieces of good news. First of all, there is no way back. And secondly, the future is not between two parallel lines. It's like that, meaning that as we speak, the scope broadens up. And there is still so many things to do. Lots of things have been addressed during this conference. And we will expect much more to come. And I hope that e-health will grow in such a controlled way that maybe within some years there would be no more need to talk about it, as it will be entirely melted in the common practice of medicine and health policies. But never forget, please, I want to paraphrase Bill Clinton, it's all about the patient, stupid. And I'm very glad that many presentations, this was brought forward. It is what it is about. It's all about the patients, in other words, for citizens, in other words, for ourselves. So it's even selfish. So let's join hands across the globe. Thank you very much.
Thank you very much indeed, Frank, for giving us co-chair, Mr. Stephen Yeo, who, as you know, is Vice President and Executive Director of the Health Information Management Systems Society, of which there are 55,000 members, many of whom I hope are in this room, Steve. So over to you.
To what you have heard earlier from the earlier panel, in fact, when I was looking at the problems and fundamental issues around the world, okay, there's not much difference in terms of what India is facing. So what I'm going to go through is really the trend that we see. There are three fundamental issues. Okay, one of them is definitely the cost. I think it's very critical in terms of when we look at the unit cost of diagnostic, unit cost of treatments, it's not going to get cheaper. Okay, there's so much of the cost implies within the healthcare system today. We also need to look into the administrative costs that actually eventually all the healthcare providers are looking at. The other areas is really the quality of care. So what kind of treatments are supposed to be administered? Okay, is it a right treatment being done? Is it a right diagnostic being done? Do we have the patient compliance? Earlier I hear a lot about training. I think it's not only training to the healthcare providers internally or your staff, but very much you need to train the patient. How do they take care of themselves? How do they comply with things that they need to do, like take the right medicine at the right time with the right amount? All right, so this goes into the quality of care. The other areas is really looking at how do we minimize, okay, medical errors, okay, and that is critical as we deliver care to the patients here. The third one is really the accessibility to care. We talk about aging population. As we all know, half the world population are in this part of the world in Asia, all right, and many countries that I see, they will never build enough hospitals to take care of the problems that they have in the next 15 to 20 years. Okay, even like Singapore as a small country, we will have 1 in 5, okay, that is above the age of 65 by the year 2020. And it will be continuing to worsen the case. And the other areas is that we will never train enough doctors or enough nurses to handle the aging populations that we have. So what do this really tell us in terms of to continue to cope with this growing demand of care delivery? So that we have to put that in mind. The other common global problems that we see are at least that we see within the hospitals. Areas like how do we provide patient safety? How do we ensure the patient privacies are there? Is there law in the country that is clearly stated on how we provide privacies of patients? How do we do engagement? Not only that we talk about hospital engaging the patients, but we need to engage the clinicians. We need to engage them, the patient, not so much the patient. We need to treat them as consumers. Especially we are going to move into the area of mHealth, and also we are putting areas where we talk about patient-centric healthcare, patient-centric care delivery, which I heard a couple of times earlier on this morning, which is really, really good. The other area is really maturity. Do we have mature process? Do we have mature staff? Do we even have mature procurements and also areas where we can create the efficiency and productivity within the people that are delivering the healthcare? Last but not least, paper management. Even though there are many countries that have said that they are moving towards the e-health or electronic medical records, however, the law still requires them to keep paper. So even though they move into EMR, they still have to print out the paper, sign the paper, and file the paper, right? Some have to be for 3 years, some 5 years, some 7 years. I haven't heard of one of the countries that they have to keep the medical record for a lifetime. So before we even think about moving into the EMR, we also need to consider all these regulations and policies that need to put in place first. So what did HIMSS really do in this case, as we move forward to it, is really that I want to make sure that this is the last slide of the problems, which is really on keeping papers management. You see the space that's going on. If you do talk about ROI, I heard people saying about ROI. If you do away your storage, okay, and move everything to E, okay, there is a big ROI if you do that calculation. And we have a lot of case study to do that as well. So what HIMSS actually do when we actually to really measure how hospitals are tracking and measuring their adoption of the EMR, HIMSS came up with this model. In fact, there are two other models that HIMSS have. One model is on the primary care, which very much focus on the outpatient. And today I'm not talking about that. Okay? What I'm going to share with you, this model is the acute care, the inpatient ward. Okay, how do you ensure that you have properly built your environment within the hospitals to be a totally paperless, chartless, filmless, digital integrated hospitals? And we have the 8 stages here. The 8 stages is range from 0 to 7. If you look at 0, it's really talking about everything is still paper. Okay, there's no computerization at all. And you go to stage 1, that means your 3 ancillaries department, whether it's the lab, the pharmacies, or the radiologies, they have to be computerized and automated and installed. Once you have done all the 3, you reach a stage 1. And moving upwards. The most critical one, okay, that to really check on a hospital to really realize their ROI is that when they hit a stage 6, very much you have a physician documentation in a structured template. You have a full CDSS, clinical decision support systems. You also have a closed-loop medication administration, which really look into patient safety here. All right, and then last, as you move into stage 7, is that everything is paperless. Everything is automated, okay, throughout the whole hospital. Even in the ER or A&E, in the emergency departments, all paper form will have to be scanned in within 24 hours. So that is how we will actually accredit, engage, and hospital, how well they actually do. For a hospital to go from stage to stage, they have to complete everything within the stage before they can move up to the next stage. Okay, if they have completed all the 2 and some of the 3 left, okay, and not completing everything in the 3, they are still at stage 2. All right, so that is how we actually measure them. This is critical. As hospitals take the survey and they take the assessment, they help the hospital to actually understand in terms of where is their benchmarking, where is their baseline. So as they implement and adopt more technology, they are able to calculate the ROIs there. So this is the tracking that we tracked for US in the past 6 years. Okay, if I look at it, is that there is a progressive growth. If you are able to measure, then you are able to track where they are. So where is the growth? In 2006, when we first reported out, 90% of the hospitals are below stage 3. As we look at 2011, it started to grow, okay, and in 2012, you can look at it, more than 80% of the hospitals are above stage 3, okay? So what actually triggers that growth here is really that in US, they actually, Obama have introduced the meaningful use of EMR. So they are now at stage 1, that is where the implementation are done. The stage 2 will be announced soon, and eventually there will be stage 3, and they need to complete everything in the year 2016. We also have tracked this across the globe in all the countries. This is not every country that I have on here. This is everything I try to put as much into one slide. But if you can track, okay, we have the Asia, we have the Middle East, we have the US, we have the Canada. Pretty much we have a majority of the data and information about the country in terms of how well they have progressed. Governments, okay, they are able to use this to make policies to allocate their resources, their budget in terms of how they do. Hospitals are able to look at, well, where can I actually push and deliver a better care to my patient. Okay, this is the tracking that we have also done within some of across each of the region. This become a very good report as people want to look at how the region are actually following up. And in Asia Pacific, we also track the growth just within Asia Pacific here. That will include hospitals from India as well in these slides. So due to time, I'm going to move pretty fast here, okay? So the cross-country in Asia, if you look at it, we have 200 over hospitals in Australia. New Zealand, we have pretty much all the 35 hospitals with the Ministry of Health here as well. And Singapore, okay, about 60% of the Singapore hospitals are now at stage 6. Okay, eventually they are planning 100% to be in stage 6 within the next 1 year, and then by stage 7 within another 18 months. This also look at if you look at Saudi, okay, we heard about Saudi. Saudi is really moving very fast in terms of adoption. We also see that there are more adoption in the private hospitals here. And just 2 months ago, the Ministry of Health in Saudi just announced that they will build another 170 hospitals in the next 5 years, just to cater to the aging population. So I'm going to move fast on this one. These are pretty much the same as what was discussed earlier on, lack of financial resources, lack of basic IT infrastructure, but not so much in terms of getting people to use it, but a strategy. Do the hospital have a strategy to implement EMR and to move throughout the stages? We do realize that they don't, because the CIO or the IT director is still unable to justify their investment. And that is the reason why this is one of the key constraints here. We also see that there is a lack of incentive for private hospitals to adopt EMR, okay, is the business forms that they might think. And then the nursing documentation not considered a priority, and that is where you see a lot of hospitals stuck at stage 2, they couldn't move up to stage 3, because the priority are put on the physician and not the nursing staff. The next one is unable to justify the returns of investment, and then managing competing priorities to meet the organization budget and goals will be critical as well. And last but not least, to reach 6 and 7, there is a critical barriers here. Very important, we talk about values. Okay, these are the values that are being driven out by the hospitals in Singapore. In each of the stages they go, they are able to quantify values, whether it's a hard saving or a soft saving. So if you all want to have more data around that, actually HIMSS do have a health IT values library that are being set up. Those that are interested can reach out to me, I can direct you to the website. So last but not least, this is my last slide here. Government and hospitals are investing in IT to deliver better patient care, safety, quality, and access. The HIMSS analytics model will be able to help to create policies and strategy. It will also drive EMR adoption and patient care. And then hospital can also learn from other hospitals that have successfully achieved the stages and getting the ROI. Last but not least, management needs to have a very clear strategy for building their EMR environment to meet the corporate objectives with its investment as well as outcome. Thank you very much. Time constraint. I'd like to introduce the next speaker, okay, which is Dr. Chris O'Connor. He's a leader in the health informatics from Canada, and he's also the founder, president, and CEO of PatientOrderSets.com and a critical care physician at Trillium's Health Partners. So let's put our hand together to welcome Chris.
Great. Well, thank you very much for having me here today. I am enormously excited to be here. Just arrived on a flight this morning, so I'm a little jet lagged still. I want to approach this from a slightly different perspective in terms of healthcare IT, in that I am a clinician, I'm a practicing critical care physician, and when I show up at work each morning to take care of my patients when I was in the ICU last week, I have this problem, which I think is one of the central challenges we face in medicine today, is that there's a massive amount of knowledge out there in all the different guidelines, textbooks, all the different reference works, web pages that sit out there, literally to the point, and this is a picture from the middle of my ICU, where we staple to a little corkboard in the middle of the unit all the best practices that we want to get to our patients. And I suspect that most people who work in a clinical environment look at one of these things when they show up to work in the morning. And this knowledge is important, it's critical for our patients, but none of it in of itself directly derives care. For our patients to get care, we have to order a lot of all the drugs and medications, laboratory tests, all the things that patients need. And traditionally we start with this. We really just start with a blank slate, and then people who practice medicine know what the next step is. We write it down by hand, from memory, by scratch, every single time. The handwriting here is an issue for sure, but at a deeper level, and this is a critical point when it comes to computerization, is that there's nothing helping you order the right thing in the right way, in a standards compliant way. So you can computerize this and make the handwriting look good, but the question is, have you embedded the knowledge into the system to make it easy to order the right thing in the right way? And more critically, to implement the knowledge into the healthcare system, which is an incredibly complex environment with multiple professions, multiple departments, and multiple processes. So the question is, can we take all this knowledge that exists out there and turn it into evidence-based checklists so that it's easy to see and easy to use, and that it's in the actual form of orders itself, so the medical knowledge becomes part of the process of care. And this is an example here I have up on the screen here that can show what it looks like in terms of having it there and how you can clearly lay out the evidence-based best practices in a checklist format. You can put it in modules, so little groups of related orders doing a common task are grouped together in one place, so it acts as a reminder. And critically, and this is a theme that already has come up several times, is that it can save people time when they're using this compared to having to create it by hand. And so really this exists in the magic quadrant, I think. It both improves quality in all kinds of different ways through a direct checklist effect and through making the healthcare team more efficiently. Critically, it saves people time, which is fantastic for adoption, because all too often, I think any clinician can speak to this, is that often people from administration and IT come down from on high and say, I want you to do this good thing, but at the same time you're going to have to work harder. And the problem with that is that people are already working very hard, and then that creates adoption problems. So save people time to get it to get the adoption you need, and impact resource utilization, and ultimately save money. Now what's interesting in medicine is that this is still a relatively new idea, starting to get some traction, but I think it's still early. There is an increasing focus on things like checklists, which are analogous to order sets but aren't quite the same thing, and things like, Dr. Atul Gawande's work around the checklist manifesto. We do know, as I flew here this morning, that aviation uses checklists pervasively through their process, and that it's very safe. And we also know in a similar way that medicine is not always as safe as we would like it. And we do have data that when you do, it works in other industries. We do have data, it's early going, that implementing order sets in the medical context does do good things, can do things like reduce length of stay, can reduce readmissions, and I won't get into the slide detail on this, but you can have a dramatic impact on the ordering of best practices across the organization, from emerge to surgery, medicine, cardiology, you name the area. One of the nice things is it can be pervasively deployed. And so if that's the good of order sets, and it's interesting because I think, it sort of passes the coffee line test. If you go down to the coffee line or wherever and just talk to people and say, what do you think of this as an idea conceptually? They're going to say, that makes intuitive sense. And in fact, they're often surprised to see that we're not doing something like this already. When you say, actually, we're not doing this. It begs the question, well, why aren't we doing this more within medicine? And when I went to build my first order set 13 years ago, because I was getting tired of writing down all my orders by hand from memory, by scratch every single time, I had an experience that I think a lot of people have when it comes to these types of tools, is you think it's going to be easy. I thought it would take me 30 minutes to build my first order set. I mean, how hard can it be? You know, you write down a few orders on a piece of paper and you should be done. Well, you know, 13 years later, here I am. I've been working at it day and night ever since. And it is an enormously complex undertaking that is deceptively complex. And it's complicated because it's a multifaceted challenge. First, on the content side, you need to have evidence-based, up-to-date content that is not only the best content, but is integrated into workflow, supports clinicians' practices, works with the regulatory environment, supports standardization, supports sharing and collaboration ideally. So you need the content. You have to figure out what's the sequence of the content, what's the clinical knowledge architecture for the content, you know, which orders are optional, which are default. You know, there's a myriad of details that go into that. And then critically, you have to keep it all up to date, and you have to get your clinicians to agree on that. But furthermore, order set doing this requires a project approach. I mean, I like to say they're very straightforward, simple undertakings. It only affects every profession in every department, almost every process in your hospital. And you have to coordinate that in an efficient way, that you do some critical things. You get people engaged, and you get consensus, and at the same time, you don't bog them down in complex processes that waste their time. And you have to solve that effectively. And if you don't solve that effectively, well, all too often what happens is an organization will go to build order sets, and then they'll find, you know, 3 to 6 months later, they say this is a great thing, but we can't get anybody to agree, and we don't know how we're going to move forward. Furthermore, you need the software tools to both manage the content of the order sets that develop your organization. You need to know who built it, when they built it, when you need to review it. That's absolute critical important. You need software, or you need an approach, whether it be pre-printed paper order sets all the way out to full CPOE systems, for completing order sets at the point of care, because if you can't complete them, then it doesn't matter how good they are. And ideally, you've got order set data. You know, how many order sets you have, you know how often they're being completed, you know by who, you can look at the variation of individual practice at the point of care, and then that provides a foundation for both engaging your clinicians, but it can also show you directly how they're actually impacting care. So it's a very simple, very straightforward idea that we just take medical knowledge and turn it into checklists so we can apply it to our patients, but it's a little more complicated and a little more challenging to actually do this effectively at the point of care. However, I think when we do this, it is absolutely foundational, because I think one of the things that we hear in IT today is, and I think people agree that we hear a lot of controversy around what is the impact of healthcare IT. There's clearly people who are huge enthusiasts. We know that there are the skeptics out there. I think the safe statement we would say at this point in time is that we're perhaps not receiving all the value for all the money we're spending, perhaps. We'd like to see more value for sure. And I think one of the reasons, complicated problem, many reasons for this, but one of the reasons for this is that all too often we're focused on the data. Well, we'll show clinicians lab results, we'll show them chest x-rays, we'll show them, you know, dictated documents. All too often we're focused on that part of the process, but we're not focused on the knowledge, and it's the knowledge that drives the care of the patient. So focusing on that and implementing that by checklists, I think, can be critically important. And the key thing here, just the final statement here, you know, use this to standardize the part of the patient's care that is routine, so we can enable our clinicians to do what they do best, which is focus on the individual needs of each individual patient. And when you do that effectively, you get the best of both worlds. Thanks very much.
Thank you very much indeed, Chris. Very insightful contribution. My pleasure now to welcome Mr. Mike Singh to address us. He's the CEO of Telcom Carib. He's held several leadership positions and numerous senior positions within AT&T in the global market. He was the Business Development Director for Latin America and the Caribbean, or should I say Caribbean basin of the...
I come humbly in the footsteps of my uncle, Sir Sridhar Ramphal, the former Foreign Minister of Guyana and Secretary General of the Commonwealth. And looking at this great gathering, just found out myself and Mr. O'Connor, both old boys of the University of Toronto, gentleman from Singapore, which I have a lot of affection for Lee Kuan Yew, and of course our colonial masters. You know, Mr. Chris represents Great Britain. Better to be a British colony than to be in a jewel in the crown of the Spanish Empire, I can assure you of that. And of course our Kiwi cousin down there in New Zealand, We buy lots of Fonterra products, lots of anchor cheese and butter and fern leaf. So we do a lot of business with you. We don't have too many Belgiums, but I have a collection of Tintin. So, quite a big gathering. Let me first of all point out, we can put this thing here right. If you look up here to the map I've got up here,